Thank you very much, and good evening to all of you. I'm sorry for the little bit of a delay because of certain technical glitches, but we welcome you uh, back again on the DY Patil Postgraduate Lecture Series. Uh, we are very happy to have with us today Dr. Ramandeep and Dr. Raju. Dr. Ramandeep will be having a discourse with you today on understanding a very complex topic, which is a conundrum for all of us. And it's always been a challenge, and today, hopefully, she will try to demystify the challenges. She'll be talking to us about the mixed states and bipolar disorder. And we are privileged to have with us today Dr. N. Raju, who is going to be chairing today's session. I've known Dr. Raju for a very long time in various capacities, but the most important manner in which I've known him is the fact that he is an extremely kind-hearted and astute gentleman who has been in various privileged positions in psychiatry across his decades of experience. He has been a past uh, Vice Dean of Andhra Medical College. Currently, he is the dean and the head of department at the Department of Psychiatry at GVP Medical College at Vishakhapatnam, and he is a consultant at Kaushalya De-Addiction and Rehab Center. But various privileged positions involved in the IPS in the past. Yes, for an entire term, he has been an EC member and an honorary general secretary of the IPS. He has authored multiple chapters in various textbooks as well as a whole range of papers. And he is a true teacher and a gentleman to boot. And we are very grateful that he could take the time out and be with us today. Welcome to the platform, Dr. Raju.
Thank you so much, Rashmit. Yes.
I will request you to take over the proceedings of the day and introduce the speaker, and then I leave it to you. Take it forward. I'll come back to you at the end of the day. Over to you, Dr. Raju.
Shall I introduce the speaker?
Yes, please. Yes,
yeah,
please.
Yeah, great. It's really my privilege. Yeah, thank you. With the outset, please let me thank DY Patil University and Dr. Rashmin in particular for giving me this opportunity of chairing or moderating a very important topic by a very important speaker. We all know that mixed affective disorders or whatever mixed states in affective disorders is a complex issue. But we have a good speaker in Dr. Ramandeep, who is a professor of psychiatry at AIIMS Delhi. She did her MBBS from Patiala and was senior resident in AIIMS. It seems all her work has been in AIIMS, and it is very good to know that. And her areas of work include bipolar and its related disorders, and lithium, suicidality, and psychiatric emergencies. And it is also very nice to know that she is in charge, faculty in charge for bipolar clinic, besides being in charge of the adult psychiatry OPD in All India Institute of Medical Sciences in Delhi. And she has many academic contributions, including training and clinical teaching for MBBS and MD psychiatry, and as a supervisor of MD thesis and PhD, and has been principal investigator and co-investigator for several projects funded by national agencies. She has over 100 peer-reviewed scientific journals and has been co-editor for 4 books and authored about 300 books. And it seems she was bestowed with many awards, including Tilak Venkobara Award in 2017, the Sir Burley Career Research Award funding 2018, co-recipient on IPS Pune Psychiatry Association Award in 2025, and another award, both to PPA 1 and PPA 2 in 2025, among other awards. And she served as a faculty resource person for training programs, contributed to technical documents, peer reviewer, examiner, and expert. I think she has everything what a psychiatrist can ask for. It is my pleasure, really, Dr. Ramdeep, to introduce you to the big and good audience. And uh, shall I hand over to Dr. Ramandeep, Dr. Ashwin?
Yes, please. Over to you, Dr. Ramandeep.
Yes.
Thank you, sir, for a generous introduction. And I'm happy to be here today. Thanks to the organizing team for giving me this opportunity. And I am happy to be with mostly a PG audience. I feel at some point, all of us are former residents and students by heart, essentially, throughout our life and careers. So it's good to interact with everyone who is here at DY Patil University. As Sir said, the topic at hand is complex, nuanced, and still evolving. So we'll try to unveil some of the complexities, and I'll try to keep it clinically grounded and evidence-based. And I hope, if not more, there are a couple of takeaways for your daily history taking as well as mental state examinations. So with this, we start. So let's try to understand the mixity. So why to bother discussing? Why bring this particular theme for discussion, especially with the PG audience? We know mixed symptoms, presentations, and states have been in discussions and in various classificatory systems for last several decades. Yet they remain poorly understood and largely unrecognized. Things have started to change mostly in the last decade or so with the advent of the recent editions of DSM and ICD. But I would like to urge all students not to view mixed states through the narrow prism of changing nosological criteria. While that is important for our clinical practice, but at the same time, it's always useful to have a little broad-based, conceptual, and historically rooted view of mixed states so that we can understand where we are today is possibly still a cross-section of a probably a evolving story. So in the next uh, uh, 40 to 45 minutes, I'll try to cover some of the clinically oriented aspects. And I do not seek to cover mixed states in a comprehensive manner. We can always leave some parts for the discussion. Now, mixed states are frequently encountered, and it's also a fact that they are not always detected. They go right under the radar of all the clinicians for various reasons, time being one of them, but also the lack of orientation and familiarity on what to look for also is another reason. Now, they are also associated with more frequent and more severe episodes, often requiring inpatient treatments. Overall, if we see the course of people having mixed features, they spend on an average less time euthymic. They also have higher rates of suicidality, both ideations as well as attempts. There are also higher rates of medical as well as psychiatric comorbidities. And overall, the guidance as far as treatments are concerned remain far from optimal. And so we hope that the outcomes are better if there is a focus towards early recognition and timely management so that some of these adverse outcomes can be prevented or managed early. So as we can see, this appears to be a more severe end of the spectrum. And while mixed states are a temporary phase for some patients, for others with more risk factors, their episodes are more often mixed than not. And so that often is a marker for a more severe subset of patient groups. Now, mixed states have also been called as missed states. And we know the dictum from all our MBBS times that eyes don't see what mind doesn't know. So our perception is shaped by the knowledge. And so we aim to know that what to look for, how to look for, which lens or which framework to use to look with, and also are we looking hard and are we looking often? So there is always a role of practice and repetition. There is always a role of screening and assessing for mixed symptoms at each visit during the acute mood episodes. For these states may not present necessarily on the first visit, but may be more clear in the second or third visit. So there is a role for looking it at each visit, and as well as devoting some time specifically to these symptoms. Now, how common are these mixed states? We have guidance from two recent systematic reviews, and that essentially is the summary or synthesis of the literature available so far. Now, this is the first systematic review from 2018. It essentially covers 2 decades of published literature from major databases, and there were a total of 17 studies with nearly 20,000 patients with mood disorders. And the pooled prevalence of mixed features was 27.8%. And this was across any index mood episode, irrespective of the polarity. Now, if we see the confidence interval, it's a relatively narrow confidence interval. I would also like to mention this 27.8, essentially over 1/4 of the patients. Here, the mixed features were taken as 3 or more contrapolar symptoms, irrespective of the fact whether they were listed in DSM or not listed. So any 3 contrapolar symptoms defined mixed features are present in over 1/4 of the patients. So this is the summary of those 17 studies. They cover a variety of geographical regions. There is also some representation from Asia, but mostly it's a Western data. And if you see the third column, 3 or more symptoms have been the most common operationally defined criteria, though some studies have also used the more narrow DSM mixed features specifier. Now, let's look individually at each episode type. How common are mixed states in MDD, bipolar depression, and bipolar mania or hypomania? So these were the prevalences from this review. In MDD, it was 23.8%. In bipolar depression, it was nearly 1/3 of the patients. And it was very similar in bipolar mania or hypomania. Now, coming to the second systematic review. Now, this was a more liberally conducted search. It included any and all kind of studies, including the retrospective chart reviews, as well as the more smaller scale data, as well as the post hoc analysis. And this covered essentially 5 years, 2013 to 2017. And with this more inclusive kind of systematic review, the pooled prevalence. Now here, what I'm highlighting is the DSM-5 defined mixed features, which is little more restrictive, as we shall see later. Now DSM-5 defined mixed features were found in 11.6% of major depressive episodes and about 1/4 of manic or hypomanic episodes. So overall, if we see, it's not uncommon, at least from what is suggested from the Western data largely, that in a more narrow sense, somewhere between 10 to 26% of mood episodes DSM defined have mixed features, and using the more broader criteria, probably much higher rates are there. Now, the East Asian data, the little data which was included in this systematic review, appeared to suggest a lower prevalence compared to the Western data, but the representation of the data was low and there were methodological differences. We have some Indian data, mainly in the form of, if we see the multi-site study, there is one multi-site study which was conducted under the aegis of IPS. And it suggested 16% prevalence of DSM-5 defined mixed features in first episode depression. And these were first episode depression, so we don't know how many of them will eventually turn out to be bipolar or not. So that was the data as far as prevalence is concerned. But what we can take home is they are not uncommon states. They appear to also have a dimensionality to it. As we know, the prevalence increases when we use the more broader diagnostic criteria, and prevalence reduces, but even with the restrictive, it appears to be present somewhere from 10 to 25% of all mood episode patients. Now, to understand where we are situated today, it's important to understand the story in very, very brief terms on how did mood states make its appearance. So I'm not going to cover the very old literature. We always know everything starts from Hippocrates, and there are indeed some descriptions from 1st or 2nd century, which probably could be roughly defined as mixed episodes, nothing conclusive. In the more modern history, the work which is particularly of significance is that of Wilhelm Weygand. Now, he was a German psychiatrist, and this was an observational work, and it marked kind of the understanding of mixed states in the more modern history. Now, he conducted his postdoctoral thesis, as it is called habilitation thesis, and he was a student of Kraepelin, so he conducted his thesis in the with Kraepelin as his chief guide or supervisor, and it was an observational work at Heidelberg Clinic, where Kraepelin worked in 1890s, and this is the data from his observational work. If we see from 1890s, of 150 patients which were reviewed, pure mania or depression was found in a very small proportion of patients, only 11. While sustained mixed episodes, agitated depression, circular cases with some mixed states were found in a large majority, and which touched almost 50% of the patients. Now, Weygand went further and also defined the 3 dimensions which we use till date. That is, he made these subtypes based on the dimensions of mood, activity levels or psychomotor levels, and thought processes. And he conceptualized that it is possible that the effect could be on the euphoric side, but at the same time could be associated with reduced activity and retarded thought processes, and various permutations and combinations of that. So Kraepelin based his concept of mixed states and put it in one of the editions of his textbook. And this visual representation also is based on Weygand's work. Now, in parallel, another significant development was in the concept of mixed depression. In older times, it used to be called as melancholia of the age of involution. That is, a very severe depression, agitated depression, which happened towards the later years of life. And another student of Kraepelin, Dreyfus, he conducted clinical investigations on this particular form of melancholia. And his thesis work, it was not a thesis work for him, his research work found that involutional melancholia had phenomenological similarities with the mixed states of MDI. And so eventually, by the 8th edition of the textbook of Kraepelin, the agitated depression or the involutional melancholia was also subsumed under the concept of MDI. So this table shows the evolution across the editions of that textbook, which PGs of that era used to read. And if we see from 4th edition till 8th edition, there have been added subtypes, and many of those subtypes are actually indicative of mixed states. For example, if we see in the last column, 5th listed one is depression with flight of ideas, and sixth is inhibited mania. So it occupied a more central place in the early part of 20th century. However, there was a shift in the dominant perspectives, especially after Kraepelin passed away, and it appears paradoxical because we associate Kraepelin mostly with polarities. But if we see from the work and including his own textbooks, he has acknowledged that mixed states are probably a norm and are very common. And he has acknowledged the work of both of his pupils, Weygand as well as Dreyfus, and based his classification on that observational work. But still, we historically associate him with polarities. So after Kraepelin passed away, the dominant narrative saw a gradual shift. And later researchers, including Jaspers as well as Schneider, were quite opposed to the dimensions of mood, activity, and thought processes, and also overlooked the existence of mixed states. In some of their papers, they are critical of mixed states, and they assume that depression or mania probably is the norm, and there is not much merit in taking the mixed states forward. And so by middle of the 20th century, mixed states were largely thought to be an oddity exception and probably clinically uncommon. So coming to the nosology and how mixed states have progressed, and this also continues the story in a way. The early editions of DSM parked mixed states either in the other category, somewhere lower down in the hierarchy, often with no associated criteria and a very brief few phrases kind of mention. So till before the third edition, mixed states did not have much of a representation other than what is shown here. Also prior to 1980, polarity did not matter, and all mood states were subsumed under the rubric of MDI. So we know even unipolar depression used to be classified as MDI. RDD was also classified as MDI, and bipolar states, as we call them today, were also MDI. The DSM-3 marked a major change because it made polarity as the basis of bifurcation of MDI. And that posed a major problem because so far, even though mixed states were not acknowledged, but they were not necessarily brushed under the carpet also. Now, because 1980 marked categorization of MDI into unipolar disorder and bipolar disorder, therefore, mixed symptoms per se did not have any particular place to go. And anyways, they were thought to be uncommon and were not factored in that decision. And DSM-3 defined mixed episode as full symptomatic picture of manic as well as major depressive episode, either intermixed or alternating every few days. And as we can see, that's almost an impossible standard to meet, at least by a large majority of patients with mixed features. So it includes meeting all the syndromal criteria of mania as well as all the syndromal criteria of depression. If we link it to what we just discussed few slides back, DSM-3 shift did not capture what Weygand observed as mixed states because he had a more nuanced dimensional approach, and he acknowledged that there could be one or two mixed features. He acknowledged that thought and activity could be different from mood. So those nuances did not get captured, and neither did what Dreyfus observed as agitated depression. Neither that was considered. So essentially, the Kraepelinian approach was then overshadowed by the Leonhardian approach. So we know Schneider-Leonhardian approach formed the basis of this separation of which happened between unipolar and bipolar states in DSM-3. So with this newer understanding, the classificatory systems went forward, and the same view was carried over in DSM-4 in 1994. And the same fundamental requirement, full manic and full depressive episode should be met and simultaneously. So this was not based on any scientific data available at the time, and more or less it was the continuity of the previous concept. So therefore it became a vicious cycle because the criteria were almost impossible to meet. The later research from 1990s onwards showed that mixed episodes were uncommon because they could not be diagnosed. So it became a vicious cycle. And in clinical practice also, they either were not seen, or even when they were seen, they were thought to be more or less same as manic episodes. And if we see most of the RCTs from those 20-30-year period, most of the RCTs have included patients with manic or mixed states without necessarily giving us the data separately. So most of the pharmacotherapies which came also did not have a separate focus on mixed episodes. So another significant development which happened after DSM-3 advent was, and this is important to understand, that there was a loss of agitation from the mixed states. So far agitation was owned by mixed states, and after DSM-3, agitation became diagnostically non-specific and could no longer be used to detect mixed states. And so this was a collateral damage which happened in the aftermath of DSM-3. And this happened because there was a bifurcation of unipolar disorder, and it was historically found that agitation could be found in unipolar depression. And so it was thought that agitation, even if we see it clinically, could still be classified as unipolar disorder, and it cannot be counted as one of the operationally defined symptoms for mixed states. So before this, if we see the work of Dreyfus, it was based on agitation being part of a mixed states, and that concept now changed. So psychomotor agitation was now diagnostically non-specific, contrary to the earlier notions. And consequently, both retarded depression patients as well as agitated depression patients could be classified under MDD criteria with no real subtypes between the two. And this is just a reminder for all of us who have till recently used DSM-4 or ICD-10. The fifth criteria from top says psychomotor agitation or retardation nearly every day. So if you see, most of the literature then will just tick it as a item which is met and won't really differentiate that which subsample or which subset had agitation and which subset had retardation. So it appeared from this that it didn't matter as long as there were psychomotor changes, they could be part of depression. Now coming to ICD-10, the mixed episode had a very brief description. Essentially, what is shown on the slide is what is described. And it also more or less carried the DSM theme that both set of syndromal symptoms should be met either as a mixture or in rapid alterations. Another thing was, in ICD-10, a single mixed episode was classified as F38, that is other. So this again I want to highlight because it has recently changed in the current DSM and in the current ICD-11. Now a single mixed episode can be classified as bipolar type 1, unlike the editions before. Now coming to some of the controversies and what is the current nosological understanding at least. So this is the DSM-5, which came in 2013, and then there was a text revision later on. So these are the criteria for mixed feature specifier for major depressive episode. Now, the first thing is that full criteria should be met for a major depressive episode. Additionally, 3 or more of the listed 7 criteria should also be met during the majority of the days of the episode. Now, if we quickly take a sneak peek on what are these 7 criteria: elevated or expansive mood, inflated self-esteem or grandiosity, more talkative than usual, flight of ideas, increase in energy, increased involvement in activities with high potential for painful consequences, and decreased need for sleep. So if we see the first 2 or 3, and we can see that there is, if a patient is meeting a full criteria for a major depressive episode, it will be very unusual for that person to also have an elevated and an expansive mood, and that too with grandiosity. Also, if we see some of the large scale data which has come in the last decade since the advent of DSM, the data do not support these listed criteria. For example, if we see this sample of Bridge 2 mixed study, the most frequent symptoms which were observed in mixed states were irritable mood, emotional lability, distractibility, and psychomotor agitation. And if we see their prevalences, irritable mood was in nearly 1/3 of the patients, and emotional lability also in nearly 30%. So every third patient had emotional lability, every fourth had distractibility. But if we see these symptoms and map it onto the previous slide, none of them appear in these listed 7 criteria, and therein lies the issue. Now, apart from these more common symptoms, the less common symptoms also include impulsivity or aggression or racing thoughts, pressure to keep talking, etc., in the background of an otherwise major depressive episode. And if we see euphoria or grandiosity, they were only somewhere between 3 to 4%, and they were less represented. And this is again from the same Bridge 2 mixed study. If we used the narrow DSM-5 criteria, only 7.5% of sample met the mixed feature specifier. But 4 times more sample, nearly 30%, met the mixed criteria if an a priori defined research-based diagnostic criteria was used. And essentially that includes a larger list of symptoms, more than those 7. Now, coming to how mixed features are defined in the manic or hypomanic episode. Now, it essentially says that 3 of the 6 listed symptoms should be present apart from a manic or hypomanic episode. And most prominent being dysphoria or depressed mood, diminished interest, retardation, etc. The criteria are more controversial for mixed feature specifier in the background of a depressive episode, though compared to in the manic episode. Now, coming to the ICD-11 perspective, that is less rigid. However, that essentially has a major difference from the DSM perspective. Now, DSM says mixed feature specifier, but ICD-11 do not have any such specifiers and instead defines only mixed episodes. And the criteria for mixed episode, while there are no countable criteria, it gives general guidelines that several prominent manic or and depressive symptoms should be present either simultaneously or they should alternate very rapidly. And it gives common contrapolar symptoms, and it acknowledges that the list is not exhaustive. So in some sense, ICD-11 perspective is better than DSM because it does not restrict to only these contrapolar symptoms. On the other hand, it does not acknowledge the mixed symptoms unless they meet this syndromal criteria of mixed episode. So there could be theoretically a manic or a depressive episode with some mixed symptoms, but not enough to reach mixed episode criteria. And they will be classified with one or the other, and their existence is not per se acknowledged. So there are some pros with DSM-5, especially in acknowledging this. The in-between gray area is much more readily acknowledged in DSM. However, the list is restrictive. On the other hand, ICD-11 follows a more categorical approach, and anything which does not fit in a manic, mixed, or depressive category, there is no dimensionality to that. So there are no specifiers to support the dimensionality. ICD-11 also focuses that in case manic and depressive episode alternate rapidly, such rapid alterations may be observed in mood. Mood can fluctuate from euphoria to sadness to dysphoria. Emotional reactivity can fluctuate from a more non-reactive effect to intense reactiveness to emotional stimuli. In clinical settings, we often seen that the interpersonal conflicts increase because the reactivity, including in personal relationships, increase as part of mixed states. And the drive also can alternate from being more retarded to more verbally expressive, even if they are telling about the sad feelings and negative states. If we see the form of it, there is a pressure to talk. There are more thoughts to share, and even if the content is negative. Cognitive functioning can also alternate from periods of some activation and inhibition and slowing of thoughts and varying attention and concentration. So ICD emphasizes on this rapid alterations and acknowledges their existence, even though it's not mandatory for diagnosis. And as I discussed earlier, presence of a single mixed episode is sufficient to make a diagnosis of bipolar type 1. And so there is no mixed episode in the background of type 2 or unipolar disorder or MDD. So this lists all the differences. DSM has no mixed episode, ICD has no mixed specifiers. We have already discussed the issue of exclusion of the contrapolar symptom list. For example, agitation is not included in MDE, and irritable mania, for example, is common, but irritability is not included for mixed feature specifier in mania. And so historically, central symptoms have been excluded from the given lists. So another thing to understand is to go beyond the nosology. If we try to understand the subjective experience or the phenomenology of mixed states, especially how it has been described by some of the key researchers who have worked in this area. So agitated depression often will manifest either in the form of pacing, hand wringing, often punching on walls. That's a common symptom which patient presents, pouncing on the door, unable to sit still, pulling or rubbing on hair, skin, clothing, and then even outbursts of complaining, even if they are complaining negativities, and general pressure to talk. Kokopoulos defined it operationally that presence of two or more of these given symptoms constitute psychomotor agitation. Now that in the background, along with psychic agitation or inner tension, racing or crowded thoughts, and these were the three main criteria. And out of this, if two of them are present, that would be sufficient for Kokopoulos's agitated mixed depression to be conceptualized. Now, mixed depression is not always agitated. There can be mixed depression without agitation. And without agitation, it can present as inner tension, that is more of psychic tension, racing or crowded thoughts, irritability or unprovoked rage, also absence of retardation. Now, there may not be agitation, but just the fact that the retardation is absent should also be made note of clinically. And then dramatic description of suffering, which is also one of the items in Kokopoulos's mixed depression rating scale, along with mood lability, marked emotional reactivity, and so on. So these are the descriptions we can, now these are very prototypical description, and not all patients have such dramatic descriptions, but somewhere to this effect can be asked in the thought form as well as the content. We can come later on how racing thoughts are different from crowded thoughts. But to sum up, racing thought is more about the flow or the acceleration of thoughts, and crowded thought, in addition to that, is also the deficit of inhibition of the previous thoughts. And residents can go and look at this particular paper to understand better. And this is where in the X and Y axis, the crowded and the racing thoughts, this is where they are placed, with crowded thoughts more towards the decreased inhibition of previous thoughts, along with production of new thoughts. So it's almost like that brain traffic. So there is a spamming of brain and there is jamming. Unlike racing thoughts, which come one after the other, but the flow keeps on happening and there is no jamming per se. Another, in very brief, issue with the current classification is the overlap between anxious distress specifier and the mixed specifier. And there is now literature to say that some of these items, like feeling keyed up or tense, feeling restless, concentration difficulties, could also overlap with patients who are experiencing mixed states. And not everyone, but subset of people with mixed states can be falsely classified as anxious distress specifier. Now, as long as we also diagnose mixed feature specifier and anxious distress specifier, it should be fine. But the problem is mixed feature specifier is very restrictive. So many of them could actually end up classified only as anxious distress and not as mixed features. And that would lead to probably overprescription of antidepressants and to take care of the anxiety. And so this misdiagnosis, so to say, can have repercussions for the clinical practice. And so this needs to be seen, and this is supported by literature also, which now in the last few years have increasingly shown this overlap, including this very good paper on symptom network analysis, where A1 is the first symptom of anxiety specifier and K1 is the Coca-Cola's first criteria. And if we see, it almost acts as a bridge and very close together on the network. So I'll skip these slides. As far as course is concerned, I'll just summarize the course. I have made a summary slide. Basically, mixed episodes are associated compared to pure mania patients with longer episodes, more severe episodes, more suicides, comorbidities, higher recurrence rates compared to pure depressive episodes. So overall, in nutshell, have a poorer prognosis. They also are associated with other clinical correlates, such as they occur at a younger age than pure episodes. And also with suboptimal treatment outcomes, including with the traditional mood stabilizers. So in 2 or 3 minutes, I would want to emphasize only certain differences from the approach of pure bipolar disorder. One is all the nosology and phenomenology which we discussed. In the clinics, one should take a careful history of these symptoms. And these symptoms include some of the non-DSM, non-ICD symptoms as well. A good practice is to always include the negative history for mixed features. As we know, there is a negative history section where we rule out all the schizophrenia, OCD, and other symptoms. It will be a useful habit to include the negative history for mixed features in all the manic and depressive episodes, which you take the history from here onwards. And even if you are saying no agitation, no inner tension, it forms a kind of a habitation of a form of habit and practice, which later will help everyone in taking the positive history as well. And even if we take a good history, mixed states are often missed in history and they are often captured in observations. So the psychopathology should be elicited in MSc. And in people who are more prone to get mixed states, such as those with early onset atypical features, those with suicidality, those with treatment emergent switch history, females those with hypothyroidism and medical comorbidities. So people with these clinical correlates, we should devote some extra time in eliciting history, because chances are they will also have mixed states. Now we use the traditional scales for assessment, but none of them capture mixed items per se. So always include the relevant tools if you get one or two mixed symptoms, because that helps in completion of the assessment. And some of the suggestions are KMDRS. It's a 14-item scale, and a score of 10 or more is indicative of mixed depression. So it will be useful to include this Coca-Cola's mixed depression rating scale. It's also useful for one's learning to include Benazzi's mixed depression criteria, which have some subtle differences, along with inventory of depressive symptomatology, the clinician rated version. So these are the three clinician administered tools. In addition to that, if the patient can understand English, Kudo's mixed scale is a useful self-report version. And there is a Hindi version, but probably that's not validated. So these are some of the suggestions to include to both screen as well as to also assess for mixed states. Now, there are also very simple clinical kind of mnemonics which have been given, such as 4 A's: anxiety, agitation, attention issues, and anger, as indicative of mixity. The overlapping symptoms have often been referred to as dip or lip symptoms: distractibility, irritability, psychomotor agitation, and lability, irritability, psychomotor agitation. Now, again, I'll not cover the management which already overlaps. I'll point out some of the differences. The treatment considerations in managing mixed states include the risk of activation and also emerging suicidality and worsening the suicidality. So both of these needs to be taken care. And if one suspects mixed features, even if they are not necessarily syndromal yet, it will be useful to monitor the patient much more frequently and possibly curtail the exposure to antidepressants, depending on the clinical condition of the patient, either to reduce the dose or stop the antidepressant prescription while continuing the rest of the medications. Sometimes patients may also need addition of or increasing the dose of benzodiazepines, especially if there is a lot of agitation, anxiety, and inner tension, as well as sleep issues. So adjusting of the prescription will be required, and exposure to monotherapy of antidepressant is simply a no-no in such a case. And there is evidence to support these suggestions also. The antidepressants seem to worsen the depression which has, and bipolar depression which has mixed states. And even if they are sub-threshold mixed states, still one should try to hold on to the same principle. Also, in STEP BD data also, for example, the antidepressant part of it necessarily did not have a better outcome compared to mood stabilizer alone. So overall emphasis, especially if it is a mixed state, depending on the mixity, there is suggestion to manage more with mood stabilizers and antipsychotics, and to reserve the antidepressants only for pure depressive states. Or even if one have to give with depression with mixed features, then the doses would need to be kept lower and patient need to be monitored very, very frequently. And it always have to be given under the cover of a good mood stabilization. The CanMat is somewhat older, and as we know, do not have any first-line agent till that time. The evidence for most of the other agent is somewhat limited, though these shown agents have some degree of evidence. So I'll skip CanMat. Subsequently, there is a more recent evidence for lumateperone in some studies, lurasidone, and all this data is summarized in a very recent review. And this kind of is a second last or last slide. This summarizes the RCT evidence which is available for MDD as well as bipolar depression with mixed features. And if we consider RCT evidence, there are only 7 studies till date. Another thing in the literature is all those studies are only short duration studies, maximum 6 to 8 weeks. But these are the agents, treatment with lurasidone, olanzapine, periprazine, lumateperone, quetiapine, and ziprasidone was associated with statistically significant reduction of depressive symptoms in major depressive episodes with mixed features. Now, only lumateperone was the molecule which was studied in both bipolar subtypes 1 and 2 as well as MDD. Lurasidone had only one study, and that too in MDD, and data for most other agents was from post hoc analysis. So to conclude, selective atypical antipsychotics are effective in alleviating symptoms of mixed features, but much of the data is available from post hoc analysis. And if we see overall number of studies, it is still emerging. And as I said before, most evidence prior to the past decade had clubbed manic episode with mixed episodes, and no separate data was available for large part when DSM-3 and DSM-4 were used. And the situation has started to change only recently. Also, at least in the published evidence, there is relatively less evidence for the traditional mood stabilizers. But as we know, published evidence is limited. And we are not treating mixed states in isolation. We are treating a patient. So if someone is maintaining well on traditional mood stabilizers such as lithium and valproate, we should see the whole lifetime course and not necessarily start tapering those mood stabilizers just because the patient is currently in mixed state. So overall, a broader perspective should be kept. At the same time, the here and now focus should be there. Now, these are some of the challenges and evolving research questions. Now, it appears prevalence is very high, depending on the study, somewhere 10 and highest 66% was found in one of the large scale studies. So if we see, it appears that mixity is definitely not rare or uncommon. It is probably present in somewhere between 1/4 to 1/3 of patients. And so is mixity the norm? Are the classic poles merely archetypes, and a majority of cases could lie somewhere in between? Also, there is a discussion, how do we define mixity? Should we define it by specifiers or by categorical, such as ICD perspective? Is one mixed symptom enough, or are 3 necessarily needed? Also, mixed features in MDD, are they still unipolar, or are they now a sign of bipolarity and eventually they will be reclassified? Also, what if the number of depressive criteria equals the hypomanic symptoms exactly? Does it still remain MDD with mixed features, or does it now meet the criteria for bipolar type 2? Also, what is unclear as of now is, are there different shades of mixed states? Should we treat all those shades differently? Would a treatment of a patient with one mixed symptom would differ from a person with who is fulfilling 5 out of those 7 criteria? Would it have implications for antidepressant prescription, for example? So, or should we treat all mixed states as one? Also, is mixity a manifestation primarily of a bipolar disorder? Or is it a true admixture, or is mixity largely driven by comorbidities, which interfere with the etiopathogenesis and change its clinical presentation? So all these remain the controversies among many others. But to conclude, concept of inherent state is not outside, it's very central to MDI. So the name, while being useful to understand the extreme poles, but it fails to acknowledge all those in-between states. And so there's a need to understand that when we are looking at a patient with bipolar disorder, mixed state is part and parcel of that and should be routine in assessment in both history and MSc. Clinical observations must be made for legacy symptoms. And there is a list of all those legacy symptoms and which in various scales also, and they should be as a routine. And agitated as well as the non-agitation phenomenology should be paid attention. So it's not that we should always overemphasize on psychomotor agitation. There are many other symptoms of mixed states which do not involve agitation. And sometimes it can be just extreme anxiety or restlessness. So apart from that, be on alert for suicidality, because that's one serious outcome, which if mixed states remain unrecognized, which is one of the complications. And so early recognition and can also contribute to prevention of suicidality. And a prescription of antidepressants should be extremely carefully reduced and stopped if as necessary, especially if psychomotor activation is observed. Take care of any risk factors for mixed states as part of clinical approach. Always rule out what are the underlying risk factors and rule out and take care of those. Prioritize mood stabilizers and atypical antipsychotics, which have evidence. And we have had a list of some of the atypical antipsychotics, which are newer ones, which have some limited evidence, but continue mood stabilizers for the larger and longer duration. And general principles of management of bipolar disorder, which apply in the disorder otherwise, should be kept into mind. Thank you.
Thank you, Dr. Ramandeep, for that excellent presentation. As you know, I think affective disorder should be on the back of your hand, and being an expert and having been working on this field for such a long period of time, it's really good to know the intricacies of mixed states in bipolar disorder, which is one very difficult to detect itself and then manage. Both are almost sometimes impossible sometimes, because we still do not know when you treat depression whether it is a natural conversion into a hypomanic state or it's just a mixed state, especially the audience is full of postgraduates. I think it's quite a challenging state, I believe, and you made things that much easier for us to understand. But I'm sure people have a lot of questions to ask. I don't know whether anything in the chat box, but if somebody is interested, perhaps I think they can raise their hand. Yeah, there is a question, few comments in childhood. There is a question from Dr. Hemant Mother, whether comments for children, anything in children. And I know you deal only adult psychiatry much. You had adult psychiatry, but somebody is interested if something is literature says something in children. Yeah.
So what is known is that early age of onset, and earlier the onset, the risk factor for mixed states is higher in the lifetime course. And my overall suggestion will be, while mixed states should be kept in mind in pediatric bipolar disorder, but it should not necessarily be the first go-to. We know there are many other conditions which can present with irritability, psychomotor agitation, especially in adolescents. And some of those reasons can be psychiatric, comorbidities, some of those reasons can also be psychological. There is not much research evidence per se as far as management of mixed states in pediatric bipolar disorder is concerned, but it would figure definitely as one of the differential diagnoses. But it should not figure very high up in adolescents. That would be my.
Anything else? I don't see anything in the chat box. And another issue in general is that earlier people thought valproate is a better choice in mixed affective disorders, mixed state. Now it seems lithium has better evidence than valproate as far as management of choice of mood stabilizers are concerned in mixed states. What is your take on this?
So if we see very strictly only RCT published evidence, as we saw in the most recent systematic review. matlab, overall, the literature on both is limited. But historically, yes, lithium have in the tables of choices between lithium and valproate, as we all are aware, lithium generally is thought to be less preferable for things such as rapid cycling and mixed states. But there is a lot of caution in making that statement. The caution is that comparison is not with valproate. Compared to its own self, compared to its own efficacy in mania, its efficacy in mixed will be less. But that's not compared to the other agent. So therein lies the catch. The over message would be that the mixed is a state. It is temporary. It pertains to this episode. And the choice of lithium and valproate should always be governed by the larger and longer course of illness. If somebody has been lithium responsive, we should continue lithium. And we should give it in optimal acute care doses. There is one caution that lithium-associated hypothyroidism may happen, especially in females who are more prone. So if we are finding a mixed state, I generally try to keep the TSH somewhere around 2.5 to 3. So even if it's upper normal 5, 5.5, 4.5, and if the person is treatment resistant, try to correct and add and keep it 2.5 or 3, not more than that, especially if the mixed state is not being controlled. So lithium can sometimes worsen, but hypothyroidism, but barring that, lithium should be continued if the patient is responsive.
There is a question, what about oxcarbamazepine and lamotrigine? And Dr. Rashmin asks, is it combination with the traditional mood stabilizer lamotrigine? So I think you can see the question in the chat box.
So we don't have an ideal agent yet for, as we saw in the CanMat tables also, there is no agent with all green, with full green circle yet. And I think the choice for the addition of lamotrigine, as we do in bipolar depression. Now the DSM, we have to understand that it has a mixed features only as a specifier. So we are still treating bipolar depression if we are going by DSM-5. And so all the agents which work in bipolar depression can technically be given, including lamotrigine.
What about these atypical antipsychotics in general in a low dose? I think it is always claimed to have an antidepressant action.
Yes.
So do we advise atypicals in depression of mixed state?
Yes, I think usually common scenario is patient is already on 1 or 2 of the traditional mood stabilizers, depending on how many past episodes. That can be valproate, that can be lithium and lamotrigine. And if the patient relapses on that and that episode has mixed state, the go-to drug for me is quetiapine. And yes, it works well in low doses. It takes care of a lot of symptoms of mixed states without necessarily worsening the activation. So any of these atypical agents, if quetiapine is very sedating, one can also go for the other atypical agents. Recently, I have also initiated lumateperone in some patients, but I'm still reserving the judgment on how efficacious it is for now. But olanzapine, quetiapine, etc., can be added.
Any more questions? What is the maximum gap between the manic and depressive source of concern? Please, you can read it in the chat box yourself.
So the criteria basically says in the same, so if we are talking about depression, in the same 2 weeks window, patient should be having most of those 3 out of those 7 symptoms for most of the days in that episode. So a large gap is not permitted, and the understanding is that usually it will be nearly every day. Mixed episode versus ultra rapid cycling, that's a very good question. There are papers on the models of mixed states, as in why, and also the causations of mixed states. And mixed states can happen either because of the treatment-induced switch. It can happen as mania is transitioning to depression. It can also happen when mania becomes, when bipolar becomes rapid cycling, and not only rapid cycling, but ultra or ultradian cycling. And the classificatory systems actually classify the ultradian or the ultra rapid as mixed states only. So the ICD perspective is, if an episode is meeting those rapidly alternating states which are changing within a day or with very close together in the same episode, ICD labels that as mixed episode. But my personal concept is there is a cycling issue and in those states, and eventually there could be subtypes of mixed states. As of now, because we are only beginning to recognize mixed states in literature only in the last 10 years or so, as we research more, it's possible it may have 2 or 3 subtypes and with different management, for example. In mixed episode patient having severe suicidal intentions, stabilized with antipsychotics and mood stabilizer, do you suggest to be cautious with antidepressants? Yes. As discussed, in a patient who is already stabilized on primary and then secondary mood stabilizing agent, if is having a significant suicidality, of course, benzodiazepines will be added and ECT will be discussed. If the patient is having very syndromal, very more clear mixed symptoms, usually I'll prefer atypical antipsychotics and try to build its dose. For example, if it's quetiapine, I'll try to build its dose to moderate to on the higher permissible side. And I'll try to avoid the antidepressants. If the suicidality is too high, I'll try to talk to the patient and caregivers about one option of ECT because it's a severe episode. But I acknowledge that this is not a norm. It's not that all 100 patients with some mixity will never be getting any antidepressants. There are always patients who show some mixed episodes at, for example, addition of 20 milligram of escitalopram in addition to their mood stabilizers. And sometimes while we are reducing, and if we stop it abruptly, sometimes they go into frank depressive episode. And so if the mixed symptoms are not much of an issue and are not associated with a lot of distress and suicidality and other activation symptoms, usually reducing the dose could work if the patient is well monitored otherwise.
I think we have come to the, I think there are no more questions. Rashmin, shall I think I can't hear your voice, but I think we had a very...
We have exhausted the questions in the chat box, unless you have any comments to make or any questions to ask.
Yeah. That's just books to study for depression. Can
Actually,
anybody search?
There are 4 very useful resources which I also never discovered in my residency. Long back, and I think I have that in my folder. I'll share it with Dr. Rashmin sir, and he can pass on.
Sure. We'll post all the resources in the groups for the postgraduate students, and we shall be anyway uploading the slide deck as well as the lecture on the website in a day or two. So all of you will have access to all the information that Dr. Ramandeep has so eloquently taught us about today. and whatever resource material she sends to me, I will post that on the WhatsApp groups as well for the postgraduate students. So you needn't worry. And if you have any further questions, queries, we can forward those to Dr. Ramandeep and she can reply back to those at her time and discretion.
My email was given at the last slide, so anyone is welcome to drop in the email.
I think, yeah.
I think my take home for students especially will be that, as I discussed, one is start including mixed features in the negative history. I think that's the first place and a very small place to start from. You may not get it, but it's always useful to ask and roll out and include in the negative history. So make that list. So that will be my number one. Number two will be always keep your radar and try to detect and diagnose. Not necessarily manage, because management is more nuanced. So my suggestion will be do the first two. And if you recognize, diagnose, always go then to your faculty consultants and then discuss how to go. So my main focus is not on management yet. I kept very few slides. The idea is to get oriented to the concept and try to detect it and not to miss it. So mixed states should not be missed states in our clinical practice. That's
very true. But just so you know, though this started off as being a program to educate postgraduate students, we've been having a large number of junior and senior consultants attend this regularly because of the quality of the topics and the speakers. So this is now not limited to students who are just appearing for their postgraduate exam. This is students who passed out many years or such as me decades back. So we continue to learn from you. But thank you. Very nice. Dr. Raju, you have any concluding remarks?
No, absolutely. I think only concluding remark is to hand over to Dr. Ashwin for thank you. Thanks. Anyway, it has been a fantastic this thing, and thank you once again for great opportunity and also great answers by Dr. Ramandeep at the end. I'm sure those questions and answers should be very useful for the postgraduates to understand. And I'm sure a few of them will take a little bit of work here and work on this. Very, very challenging, and at the same time, maybe a fluid state of mixed state. So let us see how it evolves. Over to you, Dr. Ashwin.
Thank you. Thank you very much, Dr. Raju, for your kind remarks. And again, thank you for making the time to be with us today. And thank you, Dr. Ramandeep. You did a brilliant job in trying to simplify as best as you could a very complex topic. And while I'm not sure I yet understand it as well as I ought to, but definitely I understand it a little better than I did until a couple of hours back. So thank you so much for bringing these insights to the table and to help us understand this a little bit better. And thank you to all the list of attendees today. We had everybody from postgraduate students to many residents who have passed out a while back, as well as some consultants and senior teachers as well. So thank you all for being with us and making this platform a continued form of education. And of course, thank you Sun Pharma for their unflinching support. And we promise to continue to bring you these lecture series going forward month on month. The program until March of 2026 is already posted on the website. So you have a whole bunch of exciting lectures to look forward to. And we hope you will continue to learn from these. And all these lectures are on the website for perpetuity. So all of you have free access to those slides as well as the videos forever. So please feel free to use the website to access the lectures. There's a YouTube channel which you can have free subscription to. So we hope to continue bringing these good lectures to you. And thank you all once again for being with us. And I wish you all a great evening ahead. Thank you.
Thank you. Good night.
Good night. Thank you.
Thank you.